Thank you. It's a delight being with you here today. Mechanics. So a couple things I'd like to let you know about my career and myself. I have a very eclectic career that I bring to this particular topic. I started out my training in public health. And I think it's coming full circle, finally, for us in terms of how we're thinking and how we're trying to develop solutions in addressing the problems that are really shared. It's not a problem in the United States. It's not a problem in Canada. It's not a problem in France. We're working with partners all over the world in these exact same issues. And so I'm really happy to be able to think through these issues with you. I also have business training. I have a master's in business administration from the University of Denver. I was an economist for a state legislature. And so this eclectic perspective, I think, is something that allows a discussion to happen in a much more defensible way than it has historically happened. Let's see. So for those of you who failed geography, this is where Utah is. This is where I live now. And I work at Intermountain Healthcare, as Stephen introduced me. The thing that I will say is that Intermountain Healthcare really attracted me to come there in 2008. One, because Brent James was there, who, if you've not heard him speak, is an incredible thinker in patient safety and quality improvement and has really changed and influenced the world, I think, in terms of that thinking. The other reason I came there is because Intermountain is a nonprofit healthcare delivery system in the United States. It's fully integrated across the care continuum. And because we have such a large market share in Utah, we take a real population health perspective or public health perspective in a lot of the decisions that we make. One of the basic presumptions that many of us share, and I'm equally guilty of this, is that health equals health care. I've been working in healthcare for 30 years, and we believe how do we make healthcare delivery better has been the main focus of the way we've thought about these kinds of things. But what I'd like to sort of open the discussion about today is to think about what are the social determinants, you know, in terms of those factors that relate to where you live, where you work, where you play, where you pray. And then where do you get medical care when you do need it, as an afterthought, not as a starting place. So there's a vast literature that exists on social determinants in healthcare. I've given you two examples on this particular slide. From Gallia, they looked at associations with social determinants and higher levels of mortality associated with low education level, racial segregation, low social support, poverty and low income. A recent study in 2007 from the United States National Center for Health Statistics really shows the dramatic change in rate of mortality as you move from lower education to higher education levels. These are really dramatic associations when you start to think about them. Atul Gawande, who's written quite extensively in areas like this, really talks about the critical flaw in our healthcare system, and you can read the quote here. But basically, it hasn't been designed for the kind of care that we're talking about, the kind of care that we're now sort of recognizing as we think about patient-centered care, as we think about population health. I can tell you, in 2001, I co-authored a paper with Ed Wagner and Michelle Ibrahim, and we said and concluded in that paper, now is the time for population health. I gave grand rounds at the University of Utah in the School of Medicine in 2010 and said, now really is the time for population health. And recently, last year, gave the same talk again and said, now really, really is the time for population health. We did a study at Intermountain Healthcare looking at our own data, and many people are looking at hot spotting, if you will, based on the article written by Atul Gawande. But who are the super utilizers in your healthcare delivery system? And it really came out to four buckets, if you will, or four categories or cohorts of patients. First were those people who were suffering acute events. They had been in a major car accident, for example. There are also those people with complex chronic illness. We found that if you had 3 or more chronic illnesses, didn't matter which 3, didn't matter which came first, one might be a mental health chronic illness, that categorized you as a super utilizer and put you at higher risk. And then obviously people at end-of-life care. But there was sort of this fourth cohort or category that emerged and was really related to social determinants. And in the United States, you're probably familiar with the accountable care organizations, or the ACOs. And basically what an ACO does from a Centers for Medicare and Medicaid Services perspective is to say that you're now going to be responsible for caring for this population. Anybody who lives within this geographic region, you're now going to be responsible for providing all of their care. And as I go around the United States and I talk to people in these different ACOs, one of the things that becomes apparent is they're starting to figure out these social determinants are really important. And so they're starting to think, as a healthcare delivery system, how do we address issues of housing? How do we address issues of proper nutrition? And my question to them is, are you nuts? Because the problem is a healthcare delivery system is the most expensive place to address those issues. And those people don't have experience doing it. They're social support agencies that have existed for a very, very long time. They're very knowledgeable about how to go about addressing these kinds of solutions. And so what we need to do is, instead of saying, I as a healthcare delivery system need to take responsibility for all of this, I need to figure out who my partners should be and how I leverage those partnerships in the community. And that's a challenge. And I'll talk to you a little bit about one example in the United States, or experiment, where we're trying to address that. But first, from a patient safety perspective, I've been running one of the hospital engagement networks in the United States, working with 95 hospitals across 17 states in the United States. And the Centers for Medicare and Medicaid Innovation funded 26 hospital engagement networks to address patient safety in 10 targeted areas. One of those was avoidable readmissions to the hospital. So at this point, I'm trying to make sort of the business case for you, because in the United States, there are penalties for selected readmissions to the hospital. So the hospital systems have become very, very focused on this because there's a financial incentive. And the thing that we do know is that being in the hospital is not a risk-free engagement. You open yourself up to hospital-acquired conditions. It's not the best place to be. But it's very common that there are avoidable readmissions to the hospitals. It's a focus in all of the hospitals across the United States because of the penalties, the reduced payments to the hospitals. And the literature clearly shows that it's not a one-size-fits-all approach. You know, what I do at one of Intermountain's hospitals is not necessarily what I can do at all of our hospitals. We have critical access hospitals, we have community hospitals, we have high acute tertiary care centers. And it's certainly not true for other hospitals and other places. So what we need to do as we test these experiments of change is to evaluate them so that we begin to build an evidence base for what type of intervention works in what kind of place best. Nagasako wrote an interesting article in 2014, and he suggests that if we are going to have like an organizational response, so if you're an Intermountain Healthcare with 22 hospitals, an organizational response is saying, what are we going to look at as an organization, not just at an individual hospital level and an individual unit level. And he's suggesting that really social determinants and looking at social determinants is really a target. Covello and King put out a framework. And in this framework, they have 3 different categories, basically. The kinds of risk factors that lead to readmissions in particular. And I will point, I see a couple people writing these things down. At the very end, the last slide has all of these references. So all of that information will be available. And this is a really well thought out, comprehensive model because it deals with characteristics of the individual. It deals with characteristics of the condition or the disease that they're experiencing. It talks about issues of the providers. It talks about issues of the systems and issues about the environment that people face. So when you think about sort of cause and effect from like a Centers for Medicare and Medicaid Innovation perspective, they're saying that avoidable readmissions, avoidable all-cause harm readmissions, or for cardiovascular disease, for example, are really a basis for financial penalty because it assumes that it's a result of poor quality on the part of the healthcare delivery system. And the socioeconomic factors at both the patient and the community levels have clearly been shown to be related to readmission. We did interviews with patients in our hospital engagement network, and one of the things that we found is that for some patients, it's expected. We interviewed one woman who was 62 years old. She had congestive heart failure, she had diabetes, and she had depression as a comorbidity, and she said, this is what happens to people. It wasn't unusual. She expected to be admitted to the hospital. We interviewed a homeless person, and he said, I have a safe place to sleep. I get 3 meals a day. He was happy to be admitted to the hospital. So we need to really think about and understand not just the issues on our side of the table, but the issues of the patients who are presenting to our organizations. And I think the real debate that I've noted here, and I've spoken with people at the Centers for Medicare and Medicaid Services on a number of occasions now, is should we reformulate our risk adjustment models and the penalties that are associated with these so that we have better measures, so that we're measuring the right kinds of things as we're moving forward and trying to transform the delivery system in the United States. So what do we know? We know that if you think about what are the determinants of health for anybody in this room, 20% of it has to do with your genetics, 20% of it has to do with your health care that you receive, but 60% of it is something that you personally can be accountable for. 60% of it has to do with those social, those environmental, and those behavioral characteristics. That's a huge chunk. And so for us to assume that health equals health care is really not a holistic view of what's happening and what leads to health of a population. We know from a study, and I'm going to show you the book because I think this book should be mandatory reading whatever country you live in, but basically we know in the United States for every $1 we spend in healthcare delivery, we spend 90 cents on social services. And on average, in OECD countries, for every dollar that they spend on healthcare delivery, they spend $2 on social services. And so the other point that I think is important to make is that not only does that higher ratio of social to health services lead to better patient outcomes in terms of mortality, in terms of health, we also need to know and respect the fact that these social determinants don't only apply to poor people. One of the key social determinants that we found has to do with social support. That crosses income lines. So you could be in a family situation. Imagine a family where there's a husband and wife and 3 children. The children are very active and needing to get to school. Maybe one of the children has a chronic illness, say severe asthma. The husband is diagnosed with cancer and becomes incapacitated. And now the woman who's been disconnected from her family has no social support to assist her. That changes immediately the social support that's available in that particular family, whether they're making a 6-figure income or whether they're living at poverty level. It threatens people's ability to cope and to survive. We know in the work that we've done in mental health integration that very, very complex patients can be safely treated and effectively treated in primary care as a primary care medical home when they have strong social support, when they have family cohesion. Those kinds of things are incredibly important for us to think about. So if you haven't read it, I would recommend that everybody read this book. I actually had the pleasure of meeting with the primary author last week when I was in Washington, D.C., and I'm going to show you some data that comes out of this book because I think the thing that's really interesting, and this actually started out as a New Yorker article and then has led to this particular book, they looked at the issue differently. So everybody's heard the statistic that US spends twice as much as any other OECD country, but we get less than any of those other countries. Well, this shows you, and the red arrows I'll tell you reflect where Canada is so that you can easily see them on the chart. I know they're hard to read. So the US is number 1. We spend more than anybody else. Woo! OECD on average is in that middle red bar, and you can see where Canada is. So you're pretty close to the average. One of the things that they did that was interesting is they said, well, let's really look at this differently. Let's combine healthcare delivery spending and social service spending. And actually, the US is not number 1 anymore. You start to see countries like Sweden and France, the Netherlands that are up at the higher end of the distribution. And you can see where Canada sits in there. The ratio of social to health spending, which is really the argument here, is we're now dead last in the United States. And you guys aren't close behind us. And so the issue is how are we choosing to allocate the resources that we're spending on the health of our population? And are we doing that effectively? This is just for the United States. And they did the exercise and just said, how do we distribute or allocate our social services spending in the United States? And dead last is housing. I'm on the evaluation team for the Robert Wood Johnson Foundation, and we're evaluating the Coordinated Care Organizations, or CCOs, in Oregon. They're the low-income ACOs, if you will. And I was interviewing somebody there, and he made a statement that has really stuck with me. He said, stable housing is the platform for health. And when you think about it, it really truly is. And in the United States, I would have to say that the VA health system is really leading the way in this. For over a decade, they've really incorporated housing as a key factor in thinking about how do we keep our veterans healthy. So some caveats. I think one of the big problems, for somebody who is trained in public health, we tend to medicalize health concerns. When I was in my doctoral program studying public health, obesity prevention, smoking cessation, seatbelt use, all of those things were in the domain of public health. And a lot of them are now in the domain of healthcare delivery. We have all kinds of new drugs to help prevent smoking or to allow people to quit. We've got drugs that are, I can vouch for the fact that they're not effective to help you lose weight. But we have medicalized a lot of these things that have traditionally been in the domain of public health. I was also on a Robert Wood Johnson Foundation evaluation team for the diabetes initiative that they sponsored about 7 years ago. We went around to 16 different communities in the United States, and one of the things that we saw when we were in Yuma, Arizona, a rural farming community, the lettuce capital of the United States. For those of you who are old enough, it looks like that insert to the Pink Floyd Dark Side of the Moon album. It's all this weird color of green. One of the things that we found is that people weren't able to exercise because they turned the lights off on the soccer fields, and that was the preferred exercise for people. So it was merely going to public services and recreation and saying, could you just leave the lights on until like 10 o'clock at night so people could go play soccer, so they could get something, some physical exercise built into their day. So the biggest challenge is the second bullet point here, and it's how do we transfer resources from healthcare to social services, okay? Because money is power. Where the money sits, that's where the power resides, and how do we do that? There is a major experiment, and I'll talk about it next, in the United States, where we're trying to think about it, but I have a key learning on that. We also need to think about what are we measuring, because what we measure is going to incentivize and drive how people focus their energy, their attention, and what they actually do. And so when you talk to a lot of people around the United States that I've been dealing with, we're starting to talk about, can we have some common metrics that are common to healthcare delivery and to social services, so we can start looking across that continuum. When we think about population health, I always correct people when they talk about patients. I said, no, in population health, we're talking about people. And it's better if they aren't even interacting with the healthcare delivery system because they don't need it. And that's really our goal, is how do we keep people healthy? How do we keep people well? And so things like the percent of people in our community who are housed, the percent of people who are employed, the percent who are on track to graduate from high school, the percent that are depressed in a community. How do we start to create a standardized set of measures that cross that area? And so that we can know and target from a population health perspective, if we're going to manage the health of that population, if we notice that there are high-risk areas. I forgot to tell you my PhD's and minors in medical geography, so geography always plays central in my thinking. But we could use geography to actually look at where are these target areas where there are high-risk individuals residing, so that we could send in interventions and help reach them. We did an analysis like that at Intermountain Healthcare, and we noticed there was a high ED use rate in this one area in Salt Lake City, and we actually said, well, let's get in the car and go over there and see what's happening. And it was a nursing home. And so we talked to the head of the nursing home, and she gave us a space so that we could rotate an advanced practice nurse practitioner through that nursing home and see people before they needed to get to the ED. And it's had tremendous effects, not just in terms of cost savings, which was certainly one of our goals, but in terms of satisfaction of the people. People are not looking for a chance to have an ambulance ride to the ED. And then we need to matter what matters most to the people that we're serving in our communities. I think one of the things, and I'm equally guilty of this, is we work to create validated measures and tools. And the question is, are all of our measures measuring the things that are important to people who live and reside in our communities? And so when you talk to people about what's the next generation of metrics that we're going to look at, those next generation of metrics really involve community members in helping us to identify what are the things that are important for us to be looking at. Is it really quality of life? One of the things I've done at Intermountain Healthcare is to create a standardization of a quality of life measure that we will use across the whole care continuum and across the life course. So instead of orthopedics using one measure of quality of life, maybe an SF-36, and somebody else in primary care using the PROMIS 10 global health assessment, if we all use the same measures across that continuum, we then have the ability to flip the clinic, if you will. So if we start to see that Mrs. Jones's quality of life is going down, and we know because of the treatment that she's received in her primary care medical home that she has maybe heart failure, we can not wait for her to show up at the ED or show up at the clinic. We can call her up and say, Mrs. Jones, it looks like something's not going particularly well. Would you like to schedule an appointment and come in and be seen? So different strategies to think about how we do these things and what we ask them. So if I haven't convinced you yet, hopefully you are now convinced that a population health sort of context is important for us to think about health and wellness of the populations we serve. And when you talk about population health, there are really sort of three factors that people think about. That you've committed to collaborate with some geographic responsibility. That you invest in creative and innovative approaches and study them so that you understand, do they work? Are they having the intended consequences we planned? And are there unintended consequences? And then how can we participate in coordinated efforts when we collaborate with community-based organizations, with other social welfare agencies in our communities to modify the causes of the disease? This is a really bad map, but it's the only thing I could figure out how to download off the internet. But this is Oregon. And right now in the state of Oregon in the northwestern United States, there's basically a large-scale experiment going on. There's 16 different CCOs, or coordinated care organizations, and they all look differently. The joke is sort of, if you've seen one CCO, you've seen one CCO, because they've had the latitude to be able to design how would they work with their community partners, how would they work with healthcare delivery, how would they work with health insurers in their communities. And as I said, I've been on one of the evaluation teams. This is probably the most studied experiment in US payment history, if you will. But just to give you two examples of things that they've done, and actually both of these are from Portland, Oregon. One is the Bud Clark Commons, where they've really integrated housing and health and wellness using a harm reduction model. And the thing that's really interesting about this particular model is that usually in the United States, if you are eligible to use a homeless shelter, you have to be documented to be substance abuse free. So you can't be using drugs, you can't be using alcohol. And in this particular homeless shelter, they've waived that requirement. There's another one, it's called CTRAN. It's sponsored by Oregon State Health Services University. And they've really looked at affordable housing that adds together healthcare, recovery service, and employment assistance. The thing that's different between these two is for Bud Clark Commons, that people go out into the community to receive their health care. In CTRAN, the healthcare delivery services are actually embedded in that physical location, so people aren't going anywhere. But on the evaluation that's been taking place so far, there's documented reductions in cost and utilization greater than 50%. I mean, this is huge. And reduced mortality and morbidity, which is great. So we've seen some really amazing results. So when I think about all of these different kinds of things, the sort of takeaways in my mind are that we need to really think broadly about where to find the leverage so that we can achieve a healthier society. I mean, I think that that's a responsibility that we have. We can learn from countries that have really created government ministries where they've really brought together and married health and social services. And there are a number of them. You saw them at the sort of head of the pack when we looked at that ratio. And we need to consider not just how much we're spending, but how we allocate these resources that we are spending. So how much of it is devoted to healthcare, how much of it is devoted to social welfare spending, and then incentivize the collaboration between health and social services. And that's not just through payment. That also has to do with measurement. So one of the big problems when you look at the CCOs in Oregon, they held such promise. You know, they had a lot of regulatory relief so that they actually could transfer money from healthcare delivery into social services. But all of the metrics that they're required to perform against are focused on healthcare delivery. And so when you go around and you look and see what people are doing, it's very slow in terms of the uptake of this sort of shift and this sort of collaboration that's happening. And there could be so much more done if we put the right metrics in place, because people work towards the metrics that you're holding them accountable for. It's human nature. It's organizational strategy 101. You know, if you're going to measure me on this, I'm going to outperform on it. So you all have an innovation and change agenda, which Andrew shared with me. And one of the things that I thought was really great about it is that, you know, 2 of the 4 points on this really talk about what I've been talking about. And so the question is what's your roadmap for sort of achieving these things? And what are you putting in place that's going to allow you to do that in an effective and an accelerated fashion? And I thought what was really interesting in the report were the acknowledged challenges that had been presented in that particular report. You know, so this alignment and buy-in from health authorities and other system partners to I'm going to sort of read this since I don't have this memorized, to the provincial strategy has been partial and incremental. We see that wherever we look. I'm working with people in France, I'm working with people in Sweden, you know, I'm looking at the CCOs, I'm looking at ACOs. We see this everywhere. This is a common shared problem. There have been persistent challenges in the accessibility, quality, and availability of data. Even when you look at the high-pack performers, so if you look at Sweden, if you look at France, their biggest problem is this point right here, having the data that they need. And what's the purpose the data are collected for? We're engaging on a major international comparative analysis of data. And one of the big problems you have to look at is why was the data collected and who is the data available to? And I know, like in Sweden, the registries are incredible. When I first heard about them, I thought, oh, this is a health services researcher's dream. You know, from the minute somebody's born, every place they've ever lived, you know, all the care that they've ever received. You know, isn't that amazing? The problem is they sit in these centralized registries and nobody has access to the data, and the data's not really actionable. And so it becomes a real problem. The data is also not timely in many places. In the United States, we have something called the HAC program, which doesn't mean what it sounds like, but it should. It stands for Hospital-Acquired Conditions. And they've set up this penalty program where 65% of your penalty is determined based on a composite metric of patient safety indicators, which have been shown to not be good measures in the United States. And then the remaining 35% is based on a measure for CAUTI, catheter-associated UTI, and CLABSI, central line-associated bloodstream infection. Now, here's the problem that we found in the Hospital Engagement Network, and we shared with leadership at CMS. If you're doing quality improvement and you're actually reducing the exposure, so you're reducing line days, it's going to reduce your denominator. So you could actually be doing better or at least maintaining the level of quality that you've provided, but it looks like your rate goes up. So it's an artifact of the rate itself. The other problem with that is the data they're basing these penalties on are 2 years old. So you may have fixed a major problem in your organization, but you're getting rated on that poor performance that you did 2 years ago. So we have to be careful in how we construct these measurement systems. And then, some of these key populations continue to be more vulnerable and experience poorer health and health outcomes. And so this issue of health disparities, who are the vulnerable populations that we're dealing with, and how do we best meet their needs? Salt Lake City has the second largest refugee resettlement center in the United States. And so we're dealing with immigrants from many, many different countries. There are language barriers that are associated with it, and there are cultural barriers that are associated. And so when we start to think about how do we address an issue like depression in a Hispanic population, people don't want to talk about it that way. So what we've done is we've put together lunches where we serve pizza, we have childcare, and we bring women in. And there are always advanced practice nurses with specialty mental health training who sit in there. And we just start talking and having a conversation. And when you start to learn about what people are talking about that they're experiencing things like domestic violence, or they're caught in sort of cycles of abuse. David Labby, who is a leader in one of the CCOs in Oregon, I was talking to him, and they did interviews with patients who were receiving services through the CCO, so these are lower income patients, and tried to understand what's happening in their lives. 90% of the people had personally experienced some form of physical or psychological abuse, and it had been a cross-generational issue. But we don't ever ask when somebody comes to healthcare, have you ever experienced this personally? It would be a huge risk factor for us to think about. And so trying to understand what are the right things that we're going to ask these people, how do we ask them in a way that's meaningful and acceptable to them. If you don't know, a lot of genetic research is done in Salt Lake City, Utah. One of the Nobel laureates was based in Salt Lake City. And when we talk to the Native American populations, we can't talk about genetics. It's not a word we can use. But what we learned through the focus groups is we could talk about inherited health, that was an acceptable way. So we're getting the exact same information. We're just asking about it in a way that's meaningful to people. So I hope that I've convinced you that health is not equal to just health care, and that we can really sort of shape our thinking and think through how we're going to tackle these, what seem like insurmountable problems, but I think they do have a solution, and the onus is on us together collectively, whether you're in Canada, whether you're in the United States, whether you're in Europe, for us to think about how can we address these issues in a meaningful way and create healthier communities. Thank you.